So last time we were talking about the size abnormalities, the arrangement abnormalities, and the chromasia, the abnormalities of chromasia in the RBCs. Today we will be talking about shape abnormalities in the RBCs. So yeah, it's mostly theoretical, but just try to learn the different shapes so that you can just use that morphology in your, when you have this in your mind, and when you are seeing an abnormality, then you should have some differentials in your mind, and accordingly you look for other abnormalities in that. So that's why it is important to know the various shape abnormalities of RBCs. So yeah, a few of the slides we have covered last time also, but for the sake of continuity, I will just quickly reread them. Yeah, so poikilocytosis, abnormalities of shape are called poikilocytosis. It is defined as increase in proportions of cells with abnormal shape. It may result either from the production of abnormal shaped cells by bone marrow itself, like the cells when they are produced, they are abnormal at that time only, or they may be damaged during the blood stream. So there are two types of abnormalities, and based upon the cause of the this poikilocytosis, the morphology will be different. So there are certain conditions which are associated with extreme poikilocytosis, like primary or secondary myelofibrosis, congenital or acquired dyserythropoietic anemias, hereditary pyropoikilocytosis, HPH disease, etc. And it is very important not to confuse deformation of RBCs by plasma abnormalities with true poikilocytosis. So I showed last time these two images. One is the true poikilocytosis that is seen in the hereditary pyropoikilocytosis. Then the other image is from a patient who has cryoglobulins in the plasma, and these shadows are caused by cryoglobulin deposits. So the first shape abnormality is spherocytosis. Spherocytosis sphere is a shape in which smallest shape and accommodate maximum volume. So just remember that when there is a volume excess or the membrane loss is there and the volume loss is not there, the cell will become spherical. So without the loss of cytoplasm. So that's how the cell tries to manage the volume as much as possible and acquire a spherical shape. So it can be either hereditary as seen in hereditary spherocytosis, or it can be acquired also. So how to identify a spherocyte? It is a round cell with smooth contours. Just remember smooth contours. Why I'm stressing on smooth contours? Because I will describe another cell which will have not so smooth contours. Okay. So and then characteristically they lack central pallor, and diameter is less than a discocyte of the same volume. In one of our previous lectures, we talked about the spherocytes, appearance of RBCs as spherocytes at the tail end. So never count the cells or consider the cells as spherocytes in the area of tail. Examine the area where the cells are just touching each other when you are actually seeing the central pallor in most of them. And that time, if some cells are showing a lack of central pallor and they are rounded with smooth contour, call them spherocytes. Microspherocytes, as the name suggests, are smaller in size, and they're mostly seen in the acquired conditions like clostridial sepsis, burns, and autoimmune hemolytic anemias, etc. And the term should only be used when the volume is also reduced and not just the diameter. In the spherocytes, hereditary spherocytosis, the diameter is reduced in both, but the volume will be same in the case of HS, hereditary spherocytosis, but in these acquired conditions, the volume will also be reduced. So it is very useful to distinguish between spherocytes of normal size and microspherocytes. Why? Because they have different diagnostic significance. Like I said, this image, last time also we showed it. So the first image is from a case of hereditary spherocytosis. Here you are seeing the spherocytes which are almost of similar size. You can see these are the normal looking RBCs. In between there are these spherocytes which are dark in color and they lack central pallor. Okay. So all these things, one striking thing that is there, the numbers are more, they are numerous in number, the spherocytes, and their sizes are same. While in case, so the second is an image from an autoimmune hemolytic anemia case. Here you can see the sizes of these spherocytes. This one is little bigger, this one is smaller. So the sizes are variable. And then there you are seeing these polychromatophilic cells also. So this indicates the presence of microspherocytes. So that's why it's important to determine whether it's a spherocyte or it is a microspherocyte. So the second shape abnormality that is caused by damage to the cells in the bloodstream is irregularly contracted cells. Yeah. So these cells again are smaller cells, and they also lack central payload. Just remember the cells which lack central payload. There will be coming a lot of cells which lack central payload, and you will not define them as that cell unless the central payload is missing. So irregularly contracted cell, they also lack central payload. But the difference is they are like spherocytes only, but they are not regular in shape like spherocytes. Just for the sake of terminology, they have been called irregularly contracted cells. The causes are oxidant damage. This can be because of G6PD deficiency. Drugs like dapsone, sulfur drugs, and all these can cause oxidant damage. And then membrane damage and unstable hemoglobinopathies. And very interestingly, in HBE homozygosity, they find in quite considerable number, and to a lesser extent in hemoglobin C condition. In these conditions, you will find these irregularly contracted cells. And when you are seeing irregularly contracted cells along with bite and blister cells and spherocytes, this is highly suggestive of oxidative damage, and you should advise G6PD levels in these patients. So this is an image from a case of oxidative hemolysis, showing many irregularly contracted cells with some blister cells. See the arrows which you are seeing, these are irregularly contracted cells. As I said, they are like spherocytes, but they are not perfectly round. Okay, so that's when you call them irregularly contracted cells. Some bite cells are also there. I will describe them just now after this one. So just focus on these cells. They are like spherocyte, but they are not perfectly round. So the next abnormality is bite and blister cells, again because of the damage in bloodstream. So bite cells, all these cells are smaller than normal RBCs. Okay, they lack central payload, and bite cells appears like somebody has taken a bite from the cell. Okay. So and blister cells, they are also smaller. They don't have a central payload, and they have a vacuole at one end, which is enclosed with a thin rim of cytoplasm. So it looks like a blister at one end of the cell, and the other hemoglobin is just contracted at the other end. So causes, like I said, oxidant damage, hemoglobin E conditions, on all these things, you can find these similar to the irregularly contracted cells. So this is an image of a blister cell. This image I took from our case only. So there's some stain deposits are there, but here you can see this one blister cell. The hemoglobin is concentrated at this end, and here you are seeing a vacuole which is covered by a thin layer of this cell membrane. So these are the called blister cells, and they are suggestive of oxidant damage. So here again also you can see these irregularly contracted cells are also here. They are like spherocytes but not round in shape. So all these things, they indicate oxidant damage. Yeah, so next abnormality of shape, these were about like the smaller cells which lack central payload and mostly seen these oxidant damage. Now I will be just talking about the cells which have spicules. Okay, so there are 4 types of spiculated cells which have been identified based upon the electron microscopy. Okay, so the EM structure of these cells is different. Yeah, so number 1 is schistocytes, another is keratocytes, acanthocytes, and echinocytes. So these 4 cells, they have different electron micrographic appearance. That's why they have been separated in 4 different categories. So first we will talk about schistocytes. Yeah, so schistocytes, again, they are smaller cells. By definition, they are smaller. They don't have any central payload, and they have sharp angulated edges or spines and variable shapes and sizes. Okay, so basically they are fragmented RBCs. So that's why the shapes can be highly irregular. Mostly they have sharp edges and spines. So sometimes they can have round contour also, like microspherocytes, but consider them microspherocytes and schistocytes only when the other cells are also present, the abnormal shapes. So various names have been given to these shapes like triangular cell, helmet cell, comet cell, but these are no need to describe them as separate kind of cells and just to confuse the clinician. Just call them schistocytes. Why? Because they represent the same clinical process, they have same clinical significance. So there is no need to describe them separately. Okay, you are seeing triangular cell, helmet cell. This will just increase the length of the your PVF that you are writing, and it will make no difference to the clinician or might even confuse them. So just write them as schistocyte and get done with it. They should not be more than 0.2% in healthy adults, but normally we don't see schistocytes in the peripheral bloods. So they should not be more than 0.21% in healthy adults, but they can be seen up to 1% in term neonates and up to 5% in preterm neonates. Just keep this in mind, because once I have, without knowing that the neonate was term or preterm, and I actually mentioned hemolysis in the neonate and found out later that it was a preterm neonate. So just remember that when you are seeing increased number of schistocytes, just try to inquire about their history a bit, whether it's a preterm neonate. Then in that case, the up to 5% schistocytes is also considered normal. Yeah, so schistocytes are seen, they can be seen in genetic disorders like thalassemias, congenital dyserythropoietic anemias, hereditary pyropoikilocytosis, or acquired disorders of RBC formation like megaloblastic anemia, dyserythropoietic anemias, or mechanical stress like microangiopathic hemolytic anemias, and direct thermal injuries like burns. So these are the various causes where you can find schistocytes in the blood. So like I said, just focus on the causes. When you find a certain cell, just look for the causes, because all of these have some additional abnormalities. So once you are seeing one type of cell, just try finding another type of cells that are seen in that condition, and on that basis of that, you will be able to make a diagnosis on that smear. Yeah. So it is very important to remember they can be seen in megaloblastic anemia. Don't call it a hemolytic anemia when you are seeing macrovalocytes and hypersegmented neutrophils and whatnot, all the characteristics of megaloblastic anemia, and then you are finding some schistocytes. Don't call it a case of hemolytic anemia. It's just a finding in megaloblastic anemia. Yes. And there are certain specific type of these schistocytes which have been found, like microspherocytes are found in cases of burns. In the linear fragments, I'll just show an image. They are found in the cases of sickle cell anemia. So yeah, so these are different kind of schistocytes. Here in the first image, you are seeing these irregular shaped and spines and all these this kind of schistocyte. In the second image, you are seeing one triangular shape. This one in the corner is a helmet shaped cell, another triangular cell. These are, you are finding microspherocytes here. Here you are seeing one irregularly contracted cells. So all these things, you have to call them schistocytes only. Don't call them by different names. Okay. So again, here you are seeing these microspherocytes. You can see the size, shapes are variable, and the size is pretty small. So these are microspherocytes. This was from a case of burn. Yes. And this is the another special type of schistocyte I talked about. That is the linear fragment you are seeing. So in case of sickle cell anemia, you will find this kind of schistocyte. So this is a schistocyte, not a sickle cell. I'll be showing the sickle cell image in the next few slides. Yes. So there are certain guidelines. This is an article from 2021, that is ICSH, that is International Council for Standardization in Hematology, recommendation for identification, diagnostic value, and quantitation of schistocytes. So in 2012, they gave some recommendation, and in 2021, they just saw their impact, what was the impact, and if the changes were needed. So if you guys want, you can just text me. I will share this article. It's a nice article. You can read it up. But I will just quickly cover the important findings which are given in this article. Yes. So these guidelines, mostly they are given for the recognition and enumeration of schistocytes in suspected cases of thrombotic thrombocytopenic purpura and HUS. Just remember, in these cases, the percentage of schistocytes, it's very important that they help in making the diagnosis of these conditions. So these guidelines have been specifically designed for these two conditions, but they are being used for any condition associated with schistocytosis. Yes. So one thing is, they are always smaller than intact RBC schistocytes. When do you call a cell a schistocyte? Okay, they are always smaller than intact RBC. They are homogeneously stained, and they include fragments with sharp angles and straight borders. Okay, like small crescents, helmet cells, keratocytes, and microspherocytes. Just remember about microspherocytes. Like I said previously, also, they are considered schistocytes only when the other characteristic cells like these crescents, helmet, and keratocytes, when they are present, only then you call them, count them as schistocyte. Otherwise, please don't count them as schistocytes. The second point is you have to count 1,000 erythrocytes to reach a percentage. And more than 1% of schistocytes is considered significant for these entities. But to reach that 1%, count at least 1,000 erythrocytes, either at 40x or 100x, whichever power you are convenient, that is convenient for you, you are comfortable with. Just count at that. And the quantification is only relevant when schistocytosis is dominant morphological abnormality. I will just go back to that megaloblastic anemia example with this. In megaloblastic anemia, you are finding macrocytes, macrovalocytes, and other findings, okay? But their schistocytes is not the dominant morphological abnormality. So you don't quantify. The quantification, if you do it there, it's not relevant, okay? So when schistocytosis is dominant abnormality, then only this quantification is relevant, okay? So, and again, there is one more important thing, that smears, they should be made within 3 hours when the sample is stored at room temperature, and within 8 hours when the sample is stored at 4 degrees Celsius. So the thing is, when the samples are stored for longer, they will start showing the shape abnormalities, like we talked about the storage artifact and all in our previous lectures. So they will start showing these abnormalities. So that's why it is very important that if you are getting a case of a suspected IDP or TTP or HUS, try to make slides within 3 hours when they are stored at room temperature, as early as possible. That is what I would say. And that stands true for both the peripheral blood film as well as, see, there are many analyzers available these days which actually give you the fragmented RBC count, that is called FRC. So they actually give you that count. But in that case also, you need to have the process the sample as soon as possible, because this artifact will be induced in the autoanalyzer also if the sample is kept for too long. Okay, so the another shape abnormality, the second shape abnormality of spiculated cell, that is keratocytes. Keratocytes have a pair of spicules. This could be one pair, mostly one pair, but they can be two pairs also. Mostly they have a pair of spicules. They are formed either by the removal of hinge bodies or by mechanical damage. So hinge bodies is just because formed by the precipitated globins. So in that case, you will find these. So this is an image. Here you can see there is this one beautiful keratocyte is there. There two spicules are there, and this. So here, this image is also from a case of oxidant damage, induced damage. Here you can still see these blister cells. You can see this one. There is this another blister cell. This is one irregularly contracted cell. I hope by now it is clear to you what is the difference between these cells. So the third spiculated cell is acanthocyte. It is also called spur cell. Plus, please try to call them as acanthocytes only, because there are guidelines also for that, using a standardized nomenclature. So call them acanthocytes only, but they can sometimes they are called spur cells also. There are a lot of names for acanthocytes, to be honest. Yes. So these are spherical cells until lack central palo. And because they are spherical, they will not form rulae. Okay. The spicules here are the small in number, ranging from 2 to 20, and they are distributed unevenly. Focus on the word unevenly on the RBC surface. The length is inconsistent, thickness is inconsistent, and shape is inconsistent. They can be pointy or bulbous. So in case acanthocytes, this feature is used to differentiate them from echinocytes. Okay, so the number of spicules are less, they are unevenly distributed, and they are uneven in every possible way: length, thickness, and shape. Okay. So they are often associated with abnormal phospholipid metabolism. So it is said that there is increased cholesterol in the membrane. This is a bit of technicality, but it is a nice thing to know actually. So there is increased cholesterol in the cell membrane. So here the outer membrane is expanded. So because of that, these spicules are formed. Okay. So it's often found in the conditions associated with lipid abnormalities, okay? But it can also be seen in microcytic C, based upon the disorder which you are seeing in the microcytic disorders. It can be seen in iron deficiency anemia and hemoglobinopathies. And the condition background, if you're seeing nomocytic, macrocytic RBCs, this differential diagnosis could be A-beta lipoproteinemia, liver disease, and hyposplenic states. So there are certain morphological findings of hyposplenism, like these acanthocytes, target cells, Havel-Jolly bodies. If you are seeing a lot of them, ask about the spleen status, whether it's splenectomized patient or he has or she has hyposplenism. So these are the findings associated with hyposplenism. Okay, so these are the acanthocytes. Here you can see this one has a lot of spicules. This has a very few. Here the ends are pointed, sorry, bulbous. The other one has a pointed end. So like that, they are like very uneven in shape and size. And this is reflected by this is an electron microscopic image of acanthocyte. You are seeing that it is a spherical cell with uneven multiple spicules, which are unevenly distributed, as well as they are uneven in their appearance. Many times the people who are posted in central lab, they might be getting these samples which has a request with PBF for acanthocytes. So acanthocytosis is an inherited phenomena, and it is associated with different syndromes. Most of the time this kind of request comes from the neurology department, and their presence, they may help in diagnosis. Okay, so these are the conditions which are associated with acanthocytosis, like retinitis pigmentosa, degenerative neurological diseases. Many diseases are there. They're cumulatively called as neuroacanthocytosis. Then, like I said, lipid abnormalities like fat malabsorption, A beta lipoproteinemia. In all these conditions, as an inherited phenomena, you can find acanthocytosis. So the fourth and last speculated cell is echinocyte, or another name for them is Burr cell, but it's better to describe them as echinocytes only. So these are RBCs which are covered with evenly distributed. Just focus on the differences. Acanthocytes have unevenly distributed. Here they are evenly distributed. They have few. Here they are numerous. So 2 to 20 spicules. Here they are 10 to 30 spicules. They are short. They are regular. In that case, case of acanthocytes, they were very irregular. And these echinocytes, they have central pallor. Acanthocytes, they don't have central pallor. So all these points, they will help you in differentiating these two type of speculated cells. So when you are looking at them, they resemble like a bottle cap from above. Just compare this. This is a echinocyte. This is a bottle cap. You can see the similarity. So again, this is not for the identification purpose. This is just an interesting thing to know, that they can be formed both in vivo and in vitro. Most of the time what we are seeing, they are in vitro formed, and this can be caused either by increased fatty acids or ATP depletion and lysolecithin formation. Okay, so when there is this RBCs are stored for long duration, this will help you remember why echinocytes are formed in a stored sample. Okay, so the ATPs will be depleted, and in case of storage blood for the transfusion purpose, the lysolecithin will be formed, and these things, they will cause the formation of echinocytes. But these are reversible both in vivo and in vitro. If you are if you resuspend them in fresh plasma, so they will again become the normal discocyte shape. Okay, so mostly, like I said, it is an artifactual finding, and it can be seen in films which are made from blood stored overnight at more than 20 degrees Celsius. Many times we get this kind of samples when the people draw the samples in the night. The residents, they are overworked, they draw the samples in the night, and when morning consultant asks them after the rounds, okay, send the sample, then they send the sample which have been drawn on the previous night, and then we will be seeing these kind of cells in our peripheral smear. And then the films on the slides with traces of fatty substance on the surface, that will also produce this artifact. Yeah, few crenulated cells, they can be seen in any PBF, even in the healthy subjects. Okay. So this is an example of a storage artifact. Here you are seeing many of these echinocytes. Notice these are evenly distributed, regularly spaced, regular shaped, and there is central pallor. So just remember these findings about the echinocytes. Yes. Like I said, they usually represent a storage artifact due to delay in making the film. And that's why it considered that as warning that morphological feature in the film that we are seeing, maybe it's not reliable to assess that blood film. It's a warning for that. And but if they are present in the films made from fresh blood, it is a clinically significant observation. Okay, so just ask when you are seeing a lot of echinocytes, ask the clinician or the resident when was the sample drawn. If it was a freshly drawn sample, then it is a clinical significant finding. When you are seeing marked echinocytosis in a film which is made from flesh blood, it indicates a multi-organ failure, end-stage disease and liver diseases, kidney and liver diseases. Yeah. And in the preterm units, following exchange transfusions, because of these, like I said, for the storage, RBCs, they, because they deplete the ATP and lysolecithin is formed, so they will become like echinocytes, and you will see in the case of transfusion, you will find these. And a small number of echinocytes is normal in preterm and term units. That also is you need to remember. One very important finding is there for in case of echinocytes, there is an enzyme deficiency called pyruvate kinase deficiency. Pyruvate kinase, as you know, it's associated with that glycolysis and ATP formation. So when this enzyme is deficient, RBCs will lack these ATPs, and this will result in the formation of echinocytes. So if you are seeing echinocytes in the fresh blood and it looks like a hemolytic anemia, the image is like that, then consider pyruvate kinase deficiency also and investigate for that. Yeah, so this was about the spiculated cell. Now we'll come to the another abnormality of shape, that is elongated cells. So first is elliptocytes and ovalocytes. I'm describing them together because many times we find them together. So it's just a technical term. Elliptocyte is a cell which has a length which is more than twice of the width, and in the case of ovalocytes, they're both elongated cells, so the length will be more than the width, but in case of elliptocytes, it is more than twice, and in case of ovalocytes, it is less than the 2 times of the width of the cell. When they are numerous and dominant abnormality, okay, just remember this, when you are seeing many of ovalocytes and elliptocytes, consider this as most likely it is you are dealing with the cytoskeleton abnormality like hereditary elliptocytosis. Smaller numbers, they reflect this erythropoiesis. Okay, they are commonly seen in iron deficiency anemia, beta thalassemia, primary myelofibrosis, myelodysplastic syndrome, megaloblastic anemia, in which you will be finding these macroovalocytes. Okay, and occasionally you can find them in inherited enzyme RBC enzyminopathies like pyruvate kinase deficiencies. You can find them in small numbers. Okay, the pyruvate kinase deficiency is the major abnormality is echinocytes. So in the conditions which are associated with this erythropoiesis, in these conditions, the reticulocytes are round. So that just indicates that this abnormality becomes apparent only when the cell reaches the maturity. Okay, the reticulocytes are not elongated; they are round in shape only. Okay, and about iron deficiency anemia, the number of elliptocytes and teardrop cells, they correlate with the severity of iron deficiency. So always in case when you are seeing a microscopic hypochromic picture and you are seeing these elliptocytes, try to grade them. Just try to describe them as few, they are moderate, or they are many in number, because they will just reflect the severity of this deficiency. The more severe deficiency, the more the number of these elongated cells will be. So this is an image from a case of hereditary elliptocytosis. You are seeing a lot of these elliptocytes, which are normally hemoglobinized, and these ovalocytes are also there. So this is a case of hereditary elliptocytosis. Yeah, another type of elongated cell is teardrop cells. They are commonly seen either in myelofibrosis or severe dyserythropoiesis. So you will be finding a lot of these teardrop cells in cases of megaloblastic anemia and thalassemia major, and as well as myelofibrosis, whether it's primary or secondary. And they are also commonly found in the patients with erythroleukemia. So if you are seeing a lot of these teardrop cells, then you are finding these NRBCs, and you are finding left shift, that is myelocytes, metamyelocytes and all. In these conditions, it is highly suggestive of myelofibrosis. Yeah, another type of a very specific type of a elongated cell is sickle cell. Like I said, it is very specific cell. All these cells, they have multiple differential diagnosis, but when you are seeing these sickle cells, you know that you are dealing with the case of sickle cell anemia or sickle cell disease. So they can be either sickle or crescent shaped. They have pointed ends and they lack central payload. Okay, so the cells which are looking like sickle shaped but have central payload, don't call them sickle cells. Variants are also there. Boat cells is called. It is rhomboid in shape, like it was trying to be a sickle, but the ends were cut. So it looks like that, a boat cell. It is not characteristic, but when you are finding this, it is highly suggestive. Try to look for the sickle cells. It is almost always present in freshly drawn blood of a homozygous adults. Okay, so adults who are homozygous for HBS gene, you will almost always find them. And target cells also a feature of sickle cell anemia. So you will find both these things in a case of sickle cell anemia, and they are usually absent. Okay, even when the HBS gene is there, in neonates you will not find them, and adults with high HbF condition. In both neonates and adults with high HbF, the HbF will be high. So you need a higher concentration of HbS in the cell to become a sickle cell. That's why they are usually absent in them, and they are not seen in the sickle cell trait. Okay, so if this HbS is coming, then combined this heterozygosity, you might find these, but in case of sickle cell trait, they are usually not seen. So these are the shapes of various type of sickle cells. This one is sickle shaped cell. This one is a crescent shaped cell. See, the central pallor is missing. The ends are pointed in these, and the shape is there. So these are called sickle cells. This is the image I have shown previously also in schistocyte. This one was linear fragment, and here you are seeing a boat cell. Okay, so see, the ends are like the cut from the both sides. So these are again highly suggestive, but not diagnostic. And see, there are many target cells in the background of these cells. One is here, here. Many target cells are there. So this was taken from a case of sickle cell anemia. So yeah. Then coming to the miscellaneous abnormalities of RBC shape, one is target cells. Target cells, they appear like a target. So the center is stained, and the peripheral rim of the hemoglobinized area is there. In between, there is a non-staining area. So it looks like a target. And they are formed when membrane and cell volume ratio is increased. See, remember we talked about acanthocytes, in which the outer leaflet is increased. In case of target cells, both membranes are increased. Okay, both the inner, every cell membrane has two layers, right? So outer and inner. So in this case, both layers are increased. So when there is membrane and cell volume ratio is increased, the target cells are formed. And just remember, when there is membrane and cell volume ratio is decreased, spherocytes are formed. Okay, so this just reflects that the cell volume is cell membrane is in excess to that. Again, just an interesting fact to know, does not make a difference in the diagnosis. The excess of cell membrane is due to, it can either be due to plasma lipid abnormalities, which leads to excess of membrane cholesterol, as seen in liver diseases, in which you will find normocytic and macrocytic target cells. Or the other possibilities, one is membrane is in excess, the other is the volume is decreased. That's why they are seen in these iron deficiency anemia and thalassemia. In these cases, hemoglobin is reduced, the cell volume is decreased, the amount of the membrane is still the same, then you will find these target cells. I hope this will help you remember the causes of target cells. If you remember the fact that there is a membrane is increased as compared to the cell volume. So this is an image. These target cells under the electron micrograph, they look like a bell. So when you see a bell from the top, you will see the central area and you will see the peripheral rim. So this is how they appear. So just think that this is the 3D image of this, and this is the 2D image of this. This will look like this only. This is the top of the bell, and this is the bottom periphery of the bell. Yes. Other abnormality is stomatocytes. Stomatocytes, they have central linear slit in dried films. It again is an artifact. These cells, they are cup shaped in wet preparation, like you are seeing these electron micrographic images. In these cells, the inner membrane is in excess. So we have talked about 3 membrane abnormalities. One was acanthocytes, the outer membrane was in excess. Then target cells, both membranes are in excess, and the stomatocytes where the inner membrane is in excess. So the most commonly seen in alcohol excess and alcoholic liver disease. Just remember, whenever there is a abnormality of lipid metabolism, you will find these cells. So mostly they are seen in liver diseases, all these 3 kind of cells. They're also seen in patients in hydroxycarbamide therapy and patients of myelodysplastic syndrome. So here you are seeing these slit-like spaces there. So these are, again, it's an artifact. The actual shape is not like this. So coming to the RBC inclusion. So this was about the shape abnormalities of the RBCs. Now just quickly talk about the RBC inclusions. So erythrocyte inclusions. First is Howell-Jolly bodies. They are formed by the DNA. So they are nuclear remnants and formed by either karyorexius or incomplete nuclear expulsion. They are medium-sized, round, cytoplasmic inclusions, and they stain purple. Because they are nuclear remnants, they will stain similar to the nucleus. So they will stain purple on the our routine staining. They are non-refractile. So how to distinguish from them from the stain deposits? Just adjust your fine up and down. The stain particles, they will be refractile, but these Howell-Jolly bodies, they will not be refractile. They are regularly seen after splenectomy or splenic atrophy. I talked about the features of hyposplenism or splenectomy, target cells, acanthocytes, Howell-Jolly bodies. All these things, they are found in cases of when your spleen is functioning not properly. There are normal findings in neonates due to splenic immaturity. That's why we commonly find them. The spleen is not mature enough to remove these. And usually they are only few in number. But in cases of celiac disease, you will find numerous. And in case of megaloblastic anemia, which is associated with, normally in megaloblastosis, you will find some Howell-Jolly bodies. Normally megaloblastosis doesn't have too many Howell-Jolly bodies, only a few here and there will be there. So the second erythrocyte inclusion is Pappenheimer bodies. These are composed of iron. Howell-Jolly bodies are composed of DNA. So these are smaller than these Howell-Jolly bodies. They are basophilic and ranging from light blue to black. Howell-Jolly bodies, they look like similar to the nucleus. The purple stain is there. These instead, these Pappenheimer bodies, they appear from light blue to black in color. They're usually multiple. Howell-Jolly bodies, usually they are single or maybe 2, but in case of these Pappenheimer bodies, multiple and irregular shapes are there. Howell-Jolly bodies are usually round in shape, and these focal clusters, there can be clustering, and they are usually found at the periphery of the cell. Again, Howell-Jolly bodies can also be found at the periphery, but they can be found anywhere. While these Pappenheimer bodies, they are usually present at the periphery. They are composed of hemosiderin. So their presence indicates sideroblastic erythropoiesis as well as hyposplenism. So any inclusion that is there, spleen is there to remove it. And when the spleen is not there, you will find the increased number of these inclusions in your peripheral smear. So if a cell has both Pappenheimer bodies and punctate basophilia, then you can use pearl stain to differentiate them, because these Pappenheimer bodies, they are composed of iron. The third, you must be wondering why I'm not showing the images. I will show them together so that you can make out the differences. So basophilic stippling, this is composed of RNA. So Howell-Jolly bodies, DNA, Pappenheimer bodies, iron. Basophilic stippling is composed of RNA. And there are numerous bluish granules distributed throughout the RBCs. Pappenheimer bodies are at the periphery. These basophilic stippling, it is throughout the RBCs, and they are pretty small. They may be faint and require up and down focusing to actually visualize them. And they are indicative of disturbed erythropoiesis. Okay, Howell-Jolly bodies and Pappenheimer bodies, they indicates hyposplenism usually, but these basophilic stippling is an indicative of dyserythropoiesis, and it is seen in thalassemia major and minor, megaloblastic anemia, hemolytic anemias, liver disease, dyserythropoietic states, and unstable hemoglobin. The list is actually long. I have included only the most common ones. Okay, The cases of these heavy metal poisoning, lead and other heavy metal poisoning, you will find coarse granules. Normally they are like fine granules, but in case of these heavy metal poisonings, the granules of this basophilic stippling will be coarse. So if you are seeing many cells with coarse basophilic stippling, consider these heavy metal poisonings, arsenic, lead, etc. Yeah. So this basophilic stippling is prominent in pyrimidine 5 nucleotidase deficiency because this enzyme is required for RNA degradation. So if its deficiency is there, obviously the basophilic stippling will be increased. So these are the 3 images showing different type of RBC inclusions. First image is showing these Hubble jelly bodies. You are seeing that this background is of megaloblastic anemia. You are finding these macrovalocytes and teardrop cells and some schistocytes, that's fragmented RBCs also. Spherocytes are also there. So this is one and this is another. They stain similar to the purple in color, similar to this, medium sized. Okay, so these are Hubble jelly bodies. The second image is of basophilic stippling, the 2 cells showing different kind of, one of them, this on the left is showing this fine basophilic stippling, and on the right it is showing the coarse basophilic stippling. The third image is of a cell showing, this was taken from a case of thalassemia. The Pappenheimer bodies are there. So this patient also had autoimmune hemolytic anemia simultaneously. So, but you can see there are multiple, they are like light blue to purple in color, and they are arranged at the periphery of the cells. So this is the difference between the Hubble jelly bodies and Pappenheimer bodies. I will just repeat it once more. Hubble jelly bodies are composed of DNA, basophilic stippling is composed of RNA, and Pappenheimer bodies, they are composed of iron. Okay, so the another type of RBC inclusion is caboring. We were taught that this was an artifact. Yes, this is an artifact, but this also indicates this erythropoiesis. The rings are actually formed by the remnants of microtubules that form the mitotic spindles. So they may take a form of a circle or a figure 8. And like I said, they signify this erythropoiesis. This is an image of a cell showing, this is a polychromatophilic cell, and here you are seeing this nice caboring inside this. Another type of RBC abnormality is nucleated RBCs. Normally, we don't see nucleated RBCs in the peripheral blood. They are always considered abnormal, except in cases of neonates and occasionally in pregnancy. So if you are finding RBCs, nucleated RBCs in your peripheral smear, there is something wrong going on and you have to find it. So there are few in term neonates and they're seen in very large number in preterm neonates. Okay? So just remember this, the more preterm the neonate is, the more higher will be the number of nucleated RBCs in the smear. So they are seen in increased erythropoiesis when there is marrow is just fast forward processing, producing a lot of NRBCs and then forming this. So in that case, they will be released. So in cases of severe anemia and hemolysis, you might find these NRBCs in the peripheral blood, or when there is a bone marrow infiltration. In this case, the number of these NRBCs will be disproportionately higher than the degree of anemia. Okay, like with this anemia, with increasing severity of the anemia, the number will increase. But in this cases of infiltration, if you are finding an normocytic pneumochromic anemia and the anemia is not that too high, but you are seeing a lot of these NRBCs, that will just indicate the presence of bone marrow infiltration. Why? Because in case of bone marrow infiltration, most of the time this extramedullary hematopoiesis starts. So in that case, you will find these NRBCs increased number. And then there is something called leukoerythroblastosis. When you are seeing these NRBCs with granulocytic precursors, then this will be called leukoerythroblastic picture, and it indicates either marrow infiltration or extramedullary hematopoiesis. Okay, so just remember these few things. In the case of leukoerythroblastosis with marrow infiltration, marrow fibrosis. In case of marrow fibrosis, also you will find this leukoerythroblastosis, but in that case, you will find a lot of teardrop cells also. So this is like a poorly made smear. You can see all those hydration artifacts are there. I just kept this picture only to show you this leukoerythroblastosis. This is one myeloid precursor, and here is one NRBC. If you are finding a picture like this, then call it a leukoerythroblastic picture. So this was about the RBC abnormalities. I'll just quickly go through the grading of RBC abnormalities and why it is important. Okay, so why grading is needed. Degree of a specific morphological change, it is important in determining its clinical significance. How many of a particular abnormality of the cells you are seeing, that will determine the significance of that abnormality. Yes, the examples are there. Like if you are seeing 1 or 2 target cells in the whole blood film and you are describing PBF as presence of target cells, there is no clinical relevance of these 1 or 2 target cells in the entire film. But if you keep describing this in many blood films, what will happen? The clinician will think that you will write target cells in every other blood film and he will not even pay attention to that. That's why it is very important to grade them, that how many you are seeing. Okay, so how this grading affects the clinicians? It provides them with useful information regarding the status of any abnormality in the peripheral blood. And what is the lab's responsibility? Lab's responsibility is to provide information to assist in the differential diagnosis. Okay, when we don't grade, we are not giving them useful information, and there is no point in providing bits of clinically insignificant data. That's why it is very important that you don't just describe which cells are present, you also tell how many of these cells are present. So there is this article. Again, I will share this article in the group. If you want to read it, you can just go through it. So this is again International Council of Standardization in Hematology recommendation for standardization of nomenclature and grading of peripheral blood cell morphological features. So this ICSH recommendation, it is a 2-tiered grading system. Okay, so it mostly describes cells as 2+ or 3+. 2+ is for moderate and 3+ is for many. The only exception is schistocytes. In that case, 1+ is also described, that is few or rare, because observation of the schistocytes, even in the small number, it is clinically significant. That's why only schistocytes will have 3-tiered grading system. All others will have a 2-tiered grading system. So this is a complex image. That table is given for the RBC abnormalities in this article, and I just tried to group these abnormalities for the convenience of remembering these. So first is when you are describing them, 2+ as 11 to 20 and 3+ as more than 20. So I like, just remember this, 2+, you will mostly describe them as moderate and many. So in case of size abnormalities like microcytes, macrocytes, anisocytosis, and chromasias, hypochromic cells, in these cases, you will use that 11 to 20 and more than 20% to actually describe them. So that just means that if you are seeing a cell with less percentage than this one, there is no point of describing this. If you are seeing occasional microcyte here and there, then there is no point of describing that. It is not clinically significant, so don't describe it. Okay. And the second group is when the abnormality is 5 to 20%, you will grade them as 2+, more than 20%. See, it sounds very tedious to remember that, but I would just strongly recommend to go through this article and read these abnormalities. So that will help you know when to write the abnormality. Like we are seeing a lot of abnormalities in the peripheral blood, but you don't have to describe each one of them. There is a cutoff for that, and then only you need to describe them. Okay. So for the sake of this, this polychromasia and all these other abnormalities. Okay. So ovalocyte, elliptocytes, teardrop cells, acanthocytes, echinocytes, stomatocytes, target cells. So I try to remember them as the cells which do have central payload. Okay, all these cells, other than spherocytes, they do have these central payload, and then polychromasia and basophilic stippling. The cutoff is 5%. Okay, so 5%. If they are less than 5%, you don't need to describe them. The other category is 2 to 5% 2+, and more than 5 3+. That is oval macrocytes. So you don't need to describe oval macrocytes if they are less than 2%. Okay. So even if you don't remember the entire thing, the percentage, just try to remember the first cutoff. That is like 2%, 5%, or 10%. In case of these Havel-Jolly bodies and Pappenheimer bodies, the cutoff is again 2%. These cells like bite cells, blister cells, all these cells are seen in oxidant damage. Even when you are seeing 1% of them, you have to describe them. And the last and final abnormality is schistocyte. Even when they are less than 1%, you have to describe them. Okay, so that is only one abnormality that you have to describe when it is presented less than 1%. At 1%, you have to describe the oxidant damaged cells. And above that, at 2%, you have to describe oval macrocytes and the RBC inclusions, barring basophilic stippling. So I hope this chart will help you remember these things. So general recommendation by ICSH are that provide a qualitative report, just whether the abnormality is present, whether there are few, moderate, or many for RBC abnormalities, but schistocytes count may be given as percentage, okay? Because here the percentage is important in determining the state of the follow-up and all. This is important. So it may be of clinical value for the diagnosis and follow-up cases of this HUS and TTP patients. So in that case, it is, you may describe them. Mostly we don't, but it doesn't harm. It would rather help the clinician if you describe the schistocytes as percentage. Other than these, you don't need to describe them. You can just write them few, moderate, many, or they are there or not. And for all these abnormalities, when we are giving a percentage, we have to count a minimum of 1,000 RBCs. Okay. So for the individual abnormalities, if the distribution abnormalities like agglutination and rouleau formation, if they are there, you have to report them. The presence, you don't have to grade them. You just report them whether they are there or not. In case of anisocytosis, usually we recommend that RDW is used that as for a measure of anisocytosis. But if it is unavailable, then in that case, you can describe it also. Recommended to use and report. Okay. Yes. But in that case, if it is there, then you have to grade it. Just remember, less than 10% of anisocytosis is fine. You don't have to mention it as anisocytosis. Dimorphism, if it is there, report the presence and describe the both population. It is very important that you describe both population. Don't just write dimorphic population, just describe both of them. Then hypochromia, again, it's preferable to use MCHC. But if MCHC is unavailable, then you can again grade it. And then polychromasia, it is recommended to grade as well as perform a reticulocyte count. When we were talking about polychromatophils, I told you that when we are seeing them at least 3-4 times, the reticulocyte count is at least 3-4 times of the polychromatophils that we are seeing. So we have to grade them. The cutoff for them is 5%, and you have to perform a reticulocyte count also. When in case of microcytes or macrocytes, if the RDW is within the normal range, then you can use the MCV and just report them as such that, okay, the cells are microcytic or macrocytic. But if the RDW is increased or abnormal histogram is there, in the first lecture, we talked about this is an indication of slide review. You review the slide, you grade the erythrocytes by the microscopic visual examination. But in case of oval macrocytes, they are recommended to be graded. So if you are suspecting that it could be megaloblastic anemia, just make a smear and grade the oval macrocytes. The cutoff for oval macrocytes is 2%. Then poikilocytes, don't describe them just as poikilocytosis. It is recommended by ICSH that you describe them as specific shape rather than just poikilocyte, because like we have talked about in detail, these specific shapes, they may indicate a particular diagnosis. So in that, it is important that you, it is recommended by the ICSS that you describe them as a specific shape and grade each abnormality separately. Every type of a poikilocyte, they should be graded separately. And then RBC inclusions, again, grade them individually. The recommendation is that. In case of NRBCs, it is recommended to report them as NRBC per 100 WBC and always give a corrected WBC count. In case of microorganisms, report their presence when they are there. In case of malaria, not just presence, you have to identify the species also. And in case of, we are not seeing this Plasmodium knowlesi in India, but we are seeing a lot of Plasmodium falciparum. So if the species is 2 of these, then you have to determine the parasite density also, because that is useful in clinical management and monitoring. Parasite density means you have to tell how many percentage of cells are showing or are infected with the parasite. Okay? So that is important to report in Plasmodium. Case of Plasmodium falciparum, both has for the management, because they usually have a high level of parasitemia, and high level of parasitemia is obviously the higher risk. So this article that I talked about for the grading, this also gives the nomenclature for all the RBCs. I'm not going in the detail of this nomenclature. I will just share the article. Like I said, this acanthocyte is there. They have given a recommended term for that, and they have been given a lot of synonyms which are being used for this. So it is preferable that you use this recommended nomenclature rather than using this astrocyte, burr cell, prickle cell, and whatnot. Don't use them. Try to use this recommended terminology by the ICSH. So these are the various articles and books from which I have taken all this material. So books I have already shared, and these 2 articles I'll share with you people after this session is over. Just if you want, you can go through them quickly, because the reading by yourself help in retaining it better. So that would be all for today.